Rhoads. I am the Associate Director for Community Engagement for our Cancer Center here at UCSF. And I'm also Associate Professor of Epidemiology and Biostatistics, although I'm formally trained as a colorectal surgeon, and have also additional formal training in health policy, specifically in healthcare management and reimbursement. And so my previous work has emphasized the connection between where people get care and the quality of care and outcomes for cancers of all different types in California, and in particular with an emphasis on the question of whether or not disparities are explained by quality of care. So today I actually wanted to talk to you all about comprehensive cancer centers. And just to be transparent, our community advisory board, which has been together for now 18 years, had a retreat back in August, and we were going to be in person, but then because of the mini COVID surge that we went through in the summer, we decided to do everything online. The first part of that retreat was about our CAB priorities and the activities that we wanted to see going forward with those priorities. The second part was going to be about the NCI's guidelines for community engagement, and really asking a question, taking a critical eye to whether or not those guidelines are helpful toward reaching a goal of eliminating disparities and reducing the burden of cancer in our various catchment areas. But because we weren't in person and we did it on Zoom, we weren't able to get to that second part. So we thought we would open that conversation up to the broader community. So I'm hoping to get your feedback at the end of the talk. You know, of course, we'll do Q&A, but I also want to get some feedback from you all about the guidelines that the NCI gives us that guides the work that we do in community engagement to really kind of look critically and ask a question about whether or not we could be doing more. Is there something we're missing? Effectively, what I'm always asking is, are we doing it wrong? So I'm going to go ahead and jump right in. Please feel free to put your questions in the chat. They will be captured as we move along. But we'll also have time for Q&A in the end, and I love to have folks unmute and directly ask their questions so that people hear real voices and we get real answers. All right. And also feel free to connect with each other in the chat as you see people's names and organizations coming up that you wanted to connect with, because that's a big part of what we're trying to accomplish in our community engagement efforts. All right, so what I'm going to talk about is the role of comprehensive cancer centers in improving cancer survival. So first, I'm going to start off by talking a little bit about what is a comprehensive cancer center. And I know some of you attended a talk where some of these slides were shared just last week, but I'm just going to review just briefly. So what makes a cancer center comprehensive? The comprehensive cancer centers are actually a network of federally funded institutions. The funding comes from the National Cancer Institute. And the idea here is that these institutions are committed to cancer research, treatment, and prevention. As I said, they're funded by the NCI. The grant, it lasts about 5 years, and then the cancer centers actually have to write a thousands and thousands of page application and then have a site visit from people from outside of our cancer center to determine if we really should still be indeed comprehensive. Comprehensive cancer centers are thought to play a key role in advancing cancer research and care across the country, and they have to meet rigorous criteria that is really set by the National Cancer Institute, including what you see here: demonstrated excellence in research, clinical care, community engagement, and education. And now what has recently been added is diversity, equity, inclusion. And we added accessibility. I think that's our flourish on it. And then there has to be a multidisciplinary approach to cancer research and treatment. The ultimate goal is for the cancer center to generate knowledge through research that addresses the burden of cancer in that center's catchment area. And I'll show you what our catchment area is. Each cancer center has their own. But first, just to let you know where they are in the country, there are 72 centers nationally. 54 of them are indeed what I just described as comprehensive. 11 are called cancer centers. Those are the red dots that you'll see on the map. And they just don't have that extra layer of the community engagement, the DEI pieces, and the education pieces, but they have the care and the coordination and multidisciplinary research. And then 7 are basic research labs that are not providing care at all. They're just doing research. For California, 8 of the centers are here. So that's 15% of the centers, comprehensive cancer centers nationally. 5 of them are on UC campuses, University of California. 2 are at private universities. You'll see those in purple, that's Stanford and USC. And 1 is a freestanding cancer center, meaning that's all they do there is cancer, and that's at City of Hope, and they are not affiliated with a specific university. So I know some of you may have seen signs outside of cancer centers in your neighborhood, and you're probably wondering, like, why is the comprehensive cancer center in my neighborhood not on the map I just showed you? And when these are housed in community practices or community healthcare delivery systems that are not affiliated with an academic institution, they may be part of what is called Commission on Cancer Hospitals. And the Commission on Cancer is a body that comes out of the American College of Surgeons that also does site visits and determines should this facility be a Commission on Cancer hospital. They then give accreditation, and that accreditation means that these service delivery settings have achieved certain things like comprehensive patient-centered care, multidisciplinary team approach to the delivery of that care, access to information on clinical trials. It doesn't necessarily say that clinical trials are available there. And then ongoing monitoring and follow-up, so survivorship programs. And then really the biggest element of the COC is that they're committed to quality improvement. And this is important. That means they're collecting data and they're analyzing that data to see if there are places where they can improve their quality. What's important about this is these hospitals pay to participate in data collection for quality improvement. And that means some hospitals really can't even be part of COC. This link, which I think is getting thrown in the chat or not, Eva, I did send it to you by email. If you can grab that, will allow you to put your zip code in and you can find the COC hospital nearest to you. So back to this concept of catchment area. The UCSF catchment area includes the 25 counties surrounding the Greater Bay Area. And this 25 county region includes 88% of the patient population that we see actually in our center. So when we look at the list of patients who have come through, they largely come from these 25 counties. And these 25 counties include about 1/3 of the population of the state. So 12.5 or so million lives. It's really super diverse. As you know, many of you who are from the Bay Area or live in Northern California, it's pretty diverse. So 7% African American, and this heat map is showing you the darker the colors, those are the counties where these populations are clustered. 30% Latino, and you can see that clustering there in the Central Valley. 23% Asian, really directly within the 9 counties of the Greater Bay Area. Only 1.2% Native Hawaiian or Pacific Islander, sort of focused there on the peninsula. And then 16% of our counties are rural, and those are the ones in light blue. So the question that I'm always grappling with and that I think is important, that I don't think we give enough attention to, is the question of whether or not where you go for care has any impact on what you get. So the question here is, do comprehensive cancer centers provide better outcomes after cancer care? So I want to just provide this little framework that is called the Donabadian, and Donabadian was a pathologist. He was forced to read every paper ever written in 1966 on healthcare quality, and he put healthcare quality into 3 buckets. So there's structural quality, which refers to the resources that are available to provide the care that is necessary based on the diagnosis. And so you might think about this as like the specialists that are there, the different kinds of doctors, whether or not there is an imaging center, whether or not there is access to the different kinds of treatment modalities. Is there an infusion center? Is there a radiation machine there? That's structural quality. And then there's also process quality, which is refers to the timeliness and appropriateness of care. So for the stage of disease that you have, for the type of cancer that you have, are there practices that are in place to directly address that. So some elements of process quality include like tumor boards. So does your case get discussed with a bunch of experts coming together at the same time? Do we have appropriate staging activities that you go through before you go into treatment? Do we know exactly what we're dealing with? Are there clinical trials available? Is there precision medicine or tumor genome sequencing? Can we find out everything possible about your tumor before we decide what modality to apply? And the idea that Donna Badian put together is that obviously structural quality can have an impact on process quality, and both structural and process quality can have an impact on outcome. And I like to use the little metaphor or analogy that, say you're at your friend's house and you're hungry, and you go to the refrigerator. This is structural quality. And in the refrigerator, there's Weber bread and there's a jar of peanut butter and a jar of jelly. So what you're going to have and in your process piece is making a peanut butter and jelly sandwich. But say you go to another friend's house and you open the fridge and you've got Weber bread, you've got sourdough, you've got rye bread, you've got, you know, all these different options, ciabatta, then you've got some like nice meats and cheeses and different vegetables that you can put on your sandwich, and you've got peanut butter and jelly. So your process is going to look a lot different because you have a lot of different options, and whichever sandwich you end up making is going to have a significant impact on your satisfaction. That's the outcome quality. So you can think about it like that. What does the healthcare system that you're using for your care delivery, what's in the refrigerator? Do they have everything, or do they only have a couple of things, in which case you're only getting what they have? So this is the framework in which to kind of think about outcomes and the quality of care. So if you look in the literature, there are there's a lot of evidence that you can get better outcomes at an NCI cancer center. It's been shown in pediatric blood cancers, and actually this is quite recent, out of the folks at the California Cancer Registry. And what they found was that the treatment of Ewing sarcoma and osteosarcoma at a specialized cancer center is associated with improved survival, even after you look at the tumor and say, well, this is a really bad tumor, or this tumor is, you know, not as malignant or virulent. It didn't matter. We've seen that there's decreased mortality in AML, or acute myeloid leukemia, so another blood cancer, at NCI designated cancer centers in California. So this is directly relevant to our populations and who we are here in this mix. For those of you outside, you can look for these same, who are not from California, you can look for these same kinds of articles coming out of your cancer registries if you have one. Papillary thyroid cancer, same kinds of outcomes have been shown. Similarly, in surgical outcomes, what we see is decreased inpatient mortality, decreased early mortality, more of a less impactful long-term survival after surgery in these centers, but definitely better immediate outcomes in these centers. And then finally, this article was an overview of a number of different kinds of solid tumors, and found that the odds of 1 to 3 year all cause, as well as cancer specific mortality, was actually better in comprehensive cancer centers. And I'm just curious, by way of emoji or some kind of signal, were you aware of the differences in outcome based on using a comprehensive cancer center? Just curious if people were aware of that. And I think part of that lack of awareness is there isn't a consumer reports for healthcare, right? You don't go and look it up and say, okay, which hospital is better? You think a hospital is a hospital. A hospital has all the same equipment. They're mostly the same, when in reality, they're not. And in fact, one of the key features of NCI comprehensive cancer centers is that we have clinical trials available. Okay, those clinical trials require a lot of infrastructure. That's kind of part of what comes with that grant, and the support that comes from that grant is to support this clinical trials infrastructure. So you're not going to see that at every hospital. They're not going to be available everywhere. And why does that even matter? So these next couple of papers, I'm just showing you the visuals, not really going to get into the nitty gritty, but just showing you a comparison. I think we're all have talked about the difference in survival for Black men with prostate cancer. And for the most part, the mortality is twice that of white men. However, when you're looking at, and these are comparing folks who were not treated on trial, that's the dotted orange line here in the SEER Medicare group, versus those who were treated on trial, and this is the radiation treatment oncology group or outcomes group, so RTOG. This is represented in the blue line, and what you can see is overall, this is not broken down by race. This is just overall. So people treated outside of trials had lower levels of freedom from prostate cancer specific death, okay, versus those who were on trial. So generally speaking, being on a trial can often get you better outcomes. But then when you break it down by race ethnicity, it's really important and very significant, because what you see is that the blue line at the top, so the higher the line, the better the outcome. Black men on the RTOG trials had the best outcomes compared to Black men who were just treated, off trial. And then the other two lines, yellow and purple, are everybody else, so non-Black men. And I don't know if any of you have ever seen this before, where Black patients with cancer have better outcomes than other patients. It's really unique and rare, okay? So what you can see here is that there is clearly an impact of being on a clinical trial in terms of improving survival. And I'm gonna say a little bit about why I think that's happening. This is just a second one showing that disparities gaps for men with metastatic castration-resistant prostate cancer, which is really aggressive and some of the worst. It's already moved, it's metastatic, it doesn't respond to the medication, that's the castration-resistant component. These are very aggressive and malignant tumors. But when you look at the comparison of Black and white men, that's what these two lines are here, on trial, what you see when they looked at all of the different trials, that's what this list is down here. They looked at all the different trials, compared the outcomes for Black and white men on those trials. You see that these lines are stacked right on top of each other. So there's literally no difference in outcome, in overall survival between Black and white men when Black men participate in trials. And so this is my personal take on this. Some of you have heard this before. But when you're on a clinical trial, you're not going to get, for cancer, you're not going to get a placebo like a sugar pill, because that we just aren't allowed to do that. But what you are going to get is standard of care versus maybe something that's innovative. When you're on a trial, the investigator really wants you to stay on the trial, because if you fall off the trial, and they may not know what you're getting, if you're getting experimental drug or you're getting standard of care, if you fall off of the trial protocol, when they do the data analysis, they still have to do the analysis as if you stayed on the trial. So my perception of why trials actually get you to better outcomes for racial and ethnic minorities is because somebody's actually paying attention to whether or not you get the right care. They don't know if you're getting the trial drug, but they need you to stay on trial. So that means somebody's paying attention to make sure you get at least the standard of care. And I think that's the key to what's happening here with trials. But trials aren't available everywhere, as I just said. And I just want to bring this into your awareness and imagination, that when we're struggling with, like, how do we get people on trials, and we're working so hard to do that, and we're being culturally competent inside the clinic and letting people know about trials, et cetera, the reality is it's not just about the doctor-patient interaction. This paper looked at, like, what are the barriers to getting on a trial? 55% of people with a diagnosis of cancer get treated at a place that doesn't have a trial for them. 55%. So we've already lost half of the opportunity to, quote, diversify trials, but also people have lost the opportunity for a better outcome by participating in a trial. Then when we looked at the next layer of what we lose, it's whether or not the patient has some clinical contraindication, like you can't be on the trial because one of the big ones is your kidneys don't function well, because a lot of the medications we're going to give you, your kidneys have to function in order to get rid of it. So 20% of people are being excluded because they are ineligible. And then when we ask the 14% who are left over, 6% say no, and 8% end up being enrolled. But the real point that I want to get at here is, look, 55% of people are going to institutions where there literally is no trial available for them. So how can you get that best outcome? Just want to remind you that NCI centers always have clinical trials, always. It may not be specific to every single cancer that is diagnosed, but your chances of having a trial opportunity at an NCI center is way higher, obviously, you see this 55% here, than if you're outside of an NCI center. And so the thing that I hope that folks will understand is that place matters. Where you go for your cancer treatment determines the type of care you receive, and it can influence outcomes. And I just showed you that it also can have an impact on disparities. And I know we don't think about it like this because we're mostly focused on educating people and say maybe you came with it, the stage of cancer was too advanced, and so that's why the outcomes are bad. But there's a whole body of literature I didn't show you. I've written a lot of it that actually compares stage for stage 1 versus stage 1. Depending on where you are, the outcomes are going to be a particular way, and it is heavily influenced by where you are, because there are certain things that you need, and every facility doesn't have all of those resources. Remember, process, structure, and process quality. So at this point, I've just got a couple more slides to go, and then we're going to open up the discussion. I just wanted to put a poll in front of you to ask a question. Do you need a specific type of insurance to receive care at an NCI comprehensive cancer center? So I'm just curious what awareness people have of their ability to access these resources. $20 more people, if you can. Some people are probably on a phone, they probably can't answer. Ten more seconds. All right, go ahead and close the poll. Go ahead and share the results. So great job, everybody. I'm glad that people feel like it's a free-for-all. You don't, at least for UCSF, you don't have to have a specific type of insurance, although I will say that Kaiser, there's some discussion that would need to be had about whether or not you could come over. But I think it's really important because I did attend a patient family advisory council summit, and I remember hearing someone say, UCSF is not for me. I thought it was only for wealthy people. And I just want to dispel that. And I want to make sure that people understand that if you are diagnosed with cancer, you should think about the quality of care that you're going to get when you decide where you're going to go for treatment. Okay, now all of that said, which is really that before I started doing this work in community engagement, I mean, I guess I've been doing community engagement work for a long time, but before it became my job, my research really was focused on these quality issues and these questions of quality and the questions of where people go to get their care. Now that I'm in this job leading community engagement, I'm sort of directed by what the National Cancer Institute recommends that we do in the role of Associate Director for Community Engagement. And those goals or aims are presented here. So for us, our goal in doing this community engagement work is to make sure that our research and activities are responsive to community concerns and address the burden of cancer that we can document. We know what cancers are in our catchment area. Are we addressing those? And then reducing cancer inequities, key point, in our catchment area. So here's what we've been asked to do. And what I want you to think about as I pop each of these up here is this enough? Is anything missing? What do you see that might be missing? Or do you think it's fine? So the first is for us to understand the demographics and the cancer burden in our catchment area, which I showed you all of those maps. I didn't show you the distribution of cancers, but we can create maps just like that. To engage community and catalyze research, to support equitable access to clinical trials, and to directly address the burden of cancer through education, dissemination, and health policy recommendations, and then to go beyond our catchment area and try to do that, outside of our 25 counties. And so my question that I'm putting in front of you today is, are these guidelines going to get us to better outcomes or eliminate disparities? Like, are we doing this right? And what, if anything, is missing? So I'm going to open it up for a dialogue with all of you. And there's a poll in the chat. So go ahead and vote on the poll, and then we'll open it up for some conversation and some Q&A. Can I give you 30 more seconds? Fifteen seconds. We got about, yeah, Miss McCoy, I think I hear you. Your sound is going in and out. All right, can we get one more vote in there and get us up to 75%? Great. Okay, go ahead and close the poll. All right, so I'm glad that a lot of people are comfortable with those guidelines. We've got a few people who maybe have something to add. We'll love to hear from you. And folks who are not sure, we will hopefully have an opportunity to help you, get to a point where you can make that decision. Before we go to the Q&A, I just want to thank, because I never have the opportunity to do this in these CAB2s, I want to really thank our Community Advisory Board, who hail from across our catchment area. You can see the stars on the right-hand side. They keep me honest, and quite frankly, I got screened for colorectal cancer the minute I turned 50 because I knew I would never be able to live it down or face the CAB if I didn't. And a number of people gave me the look like, you're getting screened, right? So thank you for keeping me honest. And for keeping me grounded in this work. And then I also want to acknowledge and thank our strategic partners on our joint advisory or our steering committee who join the CAB and the Cancer Center leadership as we craft the kinds of activities that our office offers. And then finally, and I really never get to do this publicly, and I just want to thank the staff in the office, because they are the ones who make these programs move forward, give them life, keep them exciting, and make sure that regardless of what the NCI tells us we need to do, that we are actually being really responsive to our community partners. Okay, and with that, I'm going to open it up for Q&A and some discussion about these guidelines. All right, so I see one hand raised, and I know that there are other things in the chat, questions in the chat. And so if I see Michael has his hand raised, go ahead and unmute, and then I'll open up the chat and look for other questions.
Thank you. Thank you for producing this Zoom meeting. It is very, very important. One of the things that I was particularly interested in, my interest was the fact that as far as Black men, or I would say Black people are concerned, is how the difference between having going through the trials and not going through the trials, how that dramatic change in events, and if we actually are able to let people know that they have access, or they may have access to it, that right there could save countless lives just on its own. So just understanding that there is a actual there is something there set up for us, that just changes the game, so to speak, and just making sure everybody is aware of it. That's one of the main things. So my question is, how do we, because like you said, it's not based, while it's not technically based from what I get on the type of insurance you have, what if though for those people who are underinsured, does that is can we get the information out to them, or do they have access to it?
Yeah, so there are ways to check if you're eligible to come to a UCSF, for example. Again, our other local cancer centers, UC Davis, Stanford, have they have different guidelines and guidance and contracts with different kinds of insurers. But I think the overarching message should be, have you checked to see if you can get your care at a comprehensive cancer center or one of their affiliates? And we do have affiliates, on this side of on the East Bay, as well as in San Francisco. So I think the point is to check and to ask. I know that when people get diagnosed with cancer, there's an automatic panic. Like, you just want, like, I want it out. I want it out now. I want it out yesterday. I want to be done with this treatment. The thing is, it doesn't grow. Cancers don't grow, on a daily basis. The time trajectories are typically in months, 3 months, 6 months, a year. So you have a moment to step back and reach to, I hope all of you now, who will tell people we should check and see if you can get into a comprehensive cancer center to get treatment for that particular cancer. And then there are folks who can check eligibility in terms of insurance, et cetera.
What about those in going through Kaiser or other such? I've come to realize that sometimes they want you to go through all the rigmaroles just to see if you can get into those specialized treatments. How do we, for those people who are finding themselves, it's hard to parlay the system, so to speak, is there any advice that we can give them?
Right. So Kaiser is the second part of why I asked that question about specific insurance. So for Kaiser, you can get a second opinion that you can pay for yourself. Often they don't really want you to move outside of the system because they are the payer. They want to pay the rates that they know that are already set versus paying a third party to provide care for your cancer. However, if you have a cancer that they really do not provide the standard of care, or cannot provide certain aspects of care that you're asking or pushing or advocating for, and you have to advocate very vigorously, then they will let you out for care elsewhere, or at least a second opinion. And sometimes there's collaboration that happens. So if your provider reaches out and or you get a second opinion from UCSF or from another cancer center, sometimes your local provider will do what is recommended by UCSF. So it's worth asking. That's really the bottom line, is to ask. There's a few questions in the chat, and then I'll go back to, I see Jill has her hand up. I think Gary asked, what is the average length of a trial and what is the percentage of Black participation? And the length of the trial really depends on the type of cancer and the trial itself and the design of the trial. So I don't think we can really provide an adequate answer to that. We do have a dashboard that allows us to follow along what percentage of African-American folks are participating in trials. And what we try to compare it to is the percentage in our catchment area. I would say, the percentage in our catchment area of African-American people is 7%. That's what we showed you. Our trials, and there's a range because there are so many trials, but there's a range anywhere from 4% up to, I've seen as high as 6%. And I know Kate's on the call. I don't know if you know off the top of your head, but I haven't seen a lot of trials that exceed the catchment area percentage for African American people on the various trials. But that is our goal, actually. And that's really one of the things that the NCI judges us on, is whether or not our representation on trials reflects our catchment area, because what we're trying to generate is data that is relevant to these 25 counties. So if we don't have 7% or more representation of African American people, then we're not really giving back the data and information that is relevant to the catchment area, as we have sort of documented, who's here. And then, should the quality of care be standardized, that there's an expectation of a generalized outcome? Yeah, there are guidelines for care, but this is kind of what I was getting at about trials. Everybody doesn't get guideline-based care. Thanks, Kate. Everybody doesn't get guideline-based care. So that's why I'm saying, if you join a trial, you're guaranteed to get that, because somebody needs you for their data purposes. They need you to actually get, either standard of care or the, whatever the innovation or trial intervention is. So again, that's why trials, I think that's the secret behind why we see these closures of disparities, gaps in these trials. Okay, I'm going to go back to Jill.
Okay, let me unmute. Yeah, I probably sound like a broken record, but I would definitely say I live in a super rural area, Mendocino County. Even within our county, there's really rural areas. Covolo's like an hour and a half from where I work. So just getting to town for anything is really difficult. And then when you're talking about getting to UCSF, it could be anywhere from like a 5 to a 7 hour round trip longer. So helping people, like making sure that people have access to immediate access to financials to get across a bridge, pay for lodging, meals while they're there. It can be 6 or 8 trips just to get the testing. Maybe they've had testing done locally, but the center wants testing done, by their own people on their own equipment, or maybe they have more sophisticated testing. So just helping people to have access to those kind of financial assistance immediately is really helpful. Even childcare, if they're leaving children behind to do a clinical trial, all of that gets super expensive. And Maite is on the call with me. She's a bilingual navigator from our center. And we talk to people all the time that they just decline a clinical trial experience because of the upfront cost. And it's really heartbreaking. So
yeah, and it really, what it reflects on, there's a couple things in what you've said. Number one, we're not regionally distributed. Number two, our trials are not what we call decentralized, so that the trials that we have in-house should be being offered closer to home, especially if the trial requires an infusion 5 days a week. I always use that example because that's the most extreme version.
Sure.
So that's something that I think that folks are trying to start to grapple with. It's unclear how to do it because, to my second point, which is medicine is a business, and it's all about follow the bouncing dollar sign. And so what would it cost for a clinic to set up a trial, or a hospital local to set up a trial? They may not actually have the resources to do that. And right now there are no mechanisms to have NCI cancer centers get additional money to finance that kind of setup. So there are some band-aids, and I would argue some really big and impactful band-aids. I don't know if anybody from Lazarus Foundation is on the call, but that their community impact program is somebody, if you're on the call, an opportunity to have some of those additional costs, reimbursed for patients and folks who want to participate in clinical trials. The other mechanism in the cancer center where I was before I came they get, there's a lot of revenue that still stays in their pockets. And so some of those funds were used in the old cancer center where I was to put people up in local lodging. So those are questions that can be asked, and I would look to organizations like yours, advocacy organizations, to help patients understand that, because obviously they're not going to know how or where or who do I ask that, right? And hopeful, again, part of one of the guidelines from NCI is to increase equitable access to clinical trials. So that may be one way, right? Funnel it through our office, and then we have to find the way or the pathway to that. And every comprehensive cancer center has a COE. So if you're not from California, you're not in Northern California, please reach out to your cancer centers, find out who that COE leader is, and ask them how they can help facilitate some of these issues. We really don't have a good, we just don't have a good mechanism for that. And yet what we're complaining about in terms of representation from our trials, like we don't have enough rural patients in the trial. Well, guess what? There's a reason. And so that needs to be directly addressed. So I would say, if you wouldn't mind, that might be a comment that we collect as part of this critique of the guidelines, right? To really explicitly address that lack of access. All right, so back into the chat. There's lots and lots of questions. And if we don't answer your question on this meeting, we will still grab them out of the chat and we will email them out to everybody. What measurement tools are used to determine and understand demographics in a catchment area? So we use a combination of tools. We use the census. We use census data. That is one of the primary tools that we use for understanding where different demographic groups live and cluster. And then we use our California Cancer Registry and our in-house registry to understand where the different cancers are distributed. And is there any data on current inequities in cancer outcomes at UCSF? So through our office, we created a program where we have representatives, early stage investigators who are interested in disparities and interested in these kinds of questions, meet together on a quarterly basis. And one of the projects that actually one of them brought to that meeting, which is, they're liaising between their research program and the community engagement group. And one of them said, I really want to look at the distribution of and use of CAR T cell therapy, which is some precision medicine, right, in our cancer center. And we looked at that. And we did find that there were disparities in access to those therapies and to those trials. And so now we're in the background. We made some changes. They were, I don't know, some of you were probably on for that call. It was about a year ago. We did make some changes and it didn't actually move the needle. So now we're trying to integrate more of the community engagement work and the office and our advocates into creating and crafting the portfolios for clinical trials, because if the portfolio is crafted toward the types of diseases that diverse populations get, then we have a better chance of actually having diverse populations get access to these trials. So we're still actually tracking that number. So as we make interventions, we'll be looking at it to see if we can, can we please move the needle on this particular outcome. So I would say, I don't know what the rest of the cancer center, I can't speak for the clinical side of the cancer center, but because my constant question is, are we doing it wrong? Is there something else we should be doing? We are taking a critical eye and trying to look at those outcomes. I don't know if you'll ever see a paper published about it because reputation, et cetera, but using the data for quality improvement internally, I think is where there's an opportunity to actually see a change. And I don't know, Ryan, I'm not sure where you're from, but for any of the early stage investigators, we are working on getting a data set that allows us to look at where people get their care and what care they got and their outcomes. And we have the hospital identification number, so we actually can look within hospital to see if there are differences in outcomes for racial and ethnic minorities. That might be a fun project for somebody who's in the right position to do that. Okay, Ms. McCoy, I see, does having Medi-Cal or Medicare preclude you from being treated at either of the Bay Area cancer centers? Great question. So for all the University of California hospitals, no. So you can come. We do accept Medi-Cal, and everybody accepts Medicare. But then when you start getting into other types of insurance products, especially HMO or what we call capitated types, and HMO you can think of as capitated. What does that mean? Capitated means that you have a diagnosis, the insurance company has a dollar amount. This is how much we're willing to spend on that diagnosis. Some of the private cancer centers that are not University of California do not have contracts with those insurance products, so they will not accept those insurance products. And I bring this up because when the Affordable Care rolled out, the ACA rolled out, all of the Medi-Cal started to become Medi-Cal managed care. So that's a capitated system. So if you had regular Medi-Cal, which just will look at the list of charges and say, okay, we're going to pay a certain amount on each of these charges. When you've got Medi-Cal managed care, it becomes capitated. So they say, you have this diagnosis, we're paying this amount of money. It doesn't matter what all was being done. So some of the private hospitals were not accepting that because they didn't want to be limited in what could be charged and what they could be reimbursed on. But for all of the University of California settings, you can come with Medi-Cal. And then recently, there was a bill passed in the California State Senate that would help patients with Medi-Cal participate in clinical trials at the 3 private institutions. It doesn't really change much for the University of California, which is 5 out of the 8. But it really does change the ability to access that kind of care at City of Hope, Stanford, and USC because they are private. UCSF affiliate sites, and also mention NCORP network, read clinical trials access and relationship with NCI designated cancer centers. I'm not aware of, thanks Michelle for this question. We do have affiliate sites, and Kate, help me because I know I'm going to forget one, but we have Marin General, we have San Mateo General, I believe. We have Washington Hospital in Fremont, and I'm forgetting 2. Kate, are you on?
We have,
oh, John Muir.
Yep.
And then there's one more. I know there's 5. So those are the affiliate sites. In terms of the NCORP network, I'm not actually sure which net and NCORP sites are networked with us. Are you aware of the local Bay Area ones, Michelle?
No, that's why I was asking, because I thought that might be helpful for all of us to know.
Yep. So I will follow up in the list of what, in the mail out that everybody gets. We'll find the NCORP sites. I don't, unless Kate has any insight on it, I'm not aware of how we connect to the NCORP sites. And Karen just put something in the chat.
Yeah, if you open it, it actually is a really nice map of all of our regional sites with their location and their phone number, contact information.
Perfect. Thank you so much. So we'll also include this link in the chat, but go ahead and click on that if you wanted to explore that a bit right now while we're still in the space. Okay. Matthew Ryan, is this the Matthew Ryan UCSF? Matthew Ryan?
Yes, yeah.
Okay, great. Because I want to point you his question. Their question is, how have we tracked how we've done historically on clinical trials? We have a dashboard called the Merit Dashboard. It's the minority enrollment in, I can't remember what it stands for, but it's minority enrollment effectively in clinical trials. And there's a dashboard that'll let you look by the different site, by the different cancer type. It'll let you look the breakdown by race, race and ethnicity, by gender, and by age, and probably some other demographic factors. So we can connect you to that if you want to be connected. I think you actually have to have a login in order to evaluate that. All right, let's see. Michael says, what if efforts are being done to share awareness of cancer centers and clinical trial treatments in sites further away from UCSF, specifically in the Central Valley, for immigrant populations who are not well versed with healthcare system? Who would be their best initial point of contact to help navigate the process of accessing cancer centers? So in the Central Valley, we're just starting to put some programming together in working with community partners and promotoras from, I think we're working with Visión y Compromiso. And that would be, I would say that's the point of contact. And that's why this network of all these people who are in this room right now, and why I'm encouraging you to connect with each other, is because you don't need the exact point person. You just need somebody who knows who the point person is to help you move through that chain. UC Fresno is in the Central Valley. Our relationship there is, in terms of cancer and cancer clinical trials, is in development. So when I listed off the network sites, I can't yet say UCSF Fresno, but I think that connection and linkage is in the works. But reach back to our office. And we'll see what we can do to try to connect people. Let's see. Stephen, I thought you had your hand up, but I don't know if you took it down.
Yes, ma'am, I did. And I was going to comment on the graph that you had, because I did do some recruitment for trials to the community. And I think that would have really been beneficial, because I got a lot of pushback because people were afraid to be in a trial because, you know, Tuskegee thing and things like that. But your presentation of the day really provided a lot of clarity on why it's important to be in a trial. And you also had the link with the increased survival rate in being in a hospital that had those trials. So I was going to say, whoever is going out there who's doing recruitment, you might want to utilize that to recruit people to be a part of a trial. Because I've been part of trials, but that was after I learned from being in support groups and various other things. I learned at UCSF how important it was. And just as your theme says, if it doesn't include us, it's not for us. And that rang very true with your presentation. And I mean, I did that. I said it to you here, but I was just going to wait to say the same thing to you next time I saw you.
Yeah, well, thank you for making that point. And I think it's not a common way that people talk about why the outcomes are better, right? I think people think the outcomes are better because you got the advanced drug, you got the innovation. That's not why. Because we know that when, and Dr. Roach, who a lot of you have worked with around prostate cancer, and he's given a lot of presentations in community, he's been, you know, pounding this drum for a long time. It's not really about race, it's about quality of care. And if people get equitable treatment for the stage of disease, for whatever we know about the particular tumor, the outcomes do not have to be disparate.
Right, but you
and that's why I make this point about clinical trials, because if you join a trial, somebody's going to make sure you get the right care, because they don't want you to mess up their data, right? And that's not happening sort of as a general rule, right? And if you're not in a trial, it's kind of like, okay, well, here's what you need to do, and you know, good luck. We're not necessarily going to help because we don't have a specific impetus to do so. But when you're on a trial, there is a specific impetus, and it is to make sure that that the trial is true to, you know, that innovation, like testing that innovation, and not because somebody fell off their treatment, right? Which would make the outcomes look worse.
I've had men push back on me. It was, oh, bro, if I get in a trial, how I know I'm not just getting a sugar pill? And what you said right there kind of...
No sugar pills.
It squashed it, but I didn't have an answer for him in the past.
Yeah. All right. So did we capture everybody's questions? If you had a question in the chat, can you please, that we didn't get to? Okay, we got 1 minute left. You can have the last word.
Yes, Dr. Rhoads. So trials basically are research oriented. And what I'd like to know is, what is the length of time that the findings of a trial become actual common practice in medical institutions, right?
It depends on the findings of the trial.
Mm.
But that's why I'm making this point right here about if you get on a trial, you're gonna get standard of care for cancer because we can't give a sugar pill. So it'll be great if the data shows that drug X is better than drug Y, and then there's a process of kind of bringing that drug in for that indication for that particular disease. But meanwhile, people can get better outcomes because they're gonna get standard care. All right, so I think there's an evaluation link that's been thrown in the chat. So please click that link. I know we didn't talk a lot about the NCI guidelines. If you have additional comments to share with us, we would love to share those back with our national network of COE, community engagement leaders, who are kind of asking this question of their community partners. Do these guidelines make sense to help us get to where we need to go? But please give us your feedback on the evaluation link. We want to know what you want to hear about next time, who you want to hear from, what those topics are, and then any feedback or advice that you have for me just as a speaker. So thank you all so much for coming. It is 1:01. I want to be respectful of your time, but I am also going to sit here in this space in case anybody is wanting to connect in the immediate moment.